And today we will discuss different types of techniques by which we extract the cataract. Cataract is defined as opacification of the normal transparent crystalline lens. So basically, there are two techniques. One is ICCE and the other is ECCE. ICC stands for intracapsular cataract extraction, and this is extracapsular cataract extraction. This one is now obsolete. What happens in it? Almost two decades ago, maybe, or some more years back, this is the lens, and what the eye specialist used to do, the opacified cataract after giving the incision. Uh, this is the limbus, this is the dilated pupil, this is 12 o'clock position. Are you getting my point? This is the picture which is being taken from the microscope, and you are seeing this eye, and this is an enlarged image. This is the limbus, this is the dilated pupil, and this is the cataract. This is 12 o'clock, and the surgeon is sitting here. Here is the feet of the patient. So the incision is given from almost, this is 12 o'clock, 1 to 2 o'clock to 10 or 11. A large incision is given, and whole of the lens is taken out. That is in anterior capsule, posterior capsule, and this cortex and nucleus. Whole the capsule is taken out through here, and ultimately what we are left with? We are left with no lens. Okay, and this is iris, and this is ciliary body, and lens is absent. It is called the state of aphakia. Now you people are faking. You are in a state of phakia, or you are faking people. This is aphakia. So after surgery, we used to give plus 10, almost plus 10 diopter, plus 10 diopter spherical of glasses, and the patient, if the surgery has gone well, he used to come was able to see 6 by 6. But this is now obsolete. Now what is the extracapsular cataract extraction? With the passage of time, when they saw the complications of intracapsular, then, as we know, uh, things changed, and what they do, they developed a technique of extracapsular cataract extraction. This is the sagittal section of the lens, and this is the nucleus. In this case, we give the incision similarly. I am telling it is a little bit fast because these are not known, routinely not done. From 2 o'clock, for example, to at the limbus, 10 o'clock, a long incision, and the whole of the lens is taken. This is the anterior capsule. It is broke. It is called cane opening anterior capsulotomy. Anterior capsule is removed first of all. Okay. Then by applying pressure, nucleus is removed. Now we are left with cortex and posterior capsule. Posterior capsule is not removed. The key of extracapsular cataract extraction and phacoemulsification is to preserve the posterior capsule. Posterior capsule must be intact, and we remove this cortex, and we are left with this posterior capsule. Okay. Similarly here, and from this wound we inserted intraocular lens which was not formed 20-30 years back. Intraocular lens, so this is the intraocular lens, it's optic. This is the haptic which goes behind the iris, and this is the second haptic which goes behind the iris. The lens is basically now it is in the anterior chamber, the artificial lens, over the posterior capsule. If, for example, it is a disastrous one of the disastrous complications that posterior capsule is ruptured during surgery, then we cannot implant the lens. So overall the concentration during the cataract surgery, because we are doing the cataract surgery on a normal eye, and if there is some pathology, for example retinal detachment, then we have already lost many things. That is a diseased eye. But in cataract, you are operating on a normal eye. If you lose something like posterior capsule rupture, then you lose many things on patient's behalf. So to do surgery on a cataractous eye is very um, uh, tricky and very sensitive business. It has to be done very, very carefully. So posterior capsule is to be retained, and this is the lens. It has got three parts, two parts you can see. This is the central part, which is called optic, and these are the two. If I draw it here like this, these are two hinges, or these are called optics, haptics. These engage the lens into the position, and this is the optic of the lens through which the rays of light converge. This is usually plus 20 diopter of spherical. But for this we do a test which is called biometry. The machine is present in the IOPD. You can see what are the requirements, and we perform biometry for every patient before cataract surgery, and usually the patient uh, number which comes out of biometry is plus 18, plus 20, plus 90, plus 21, plus 22. This is the normal range, but to be on the exact side we perform it, and after this surgery the aphakic glasses or plus 10 glasses are not required, which have their own complications. And then we apply, as in intracapsular, extracapsular, uh, you, we apply five sutures, one in the center, one here, and five here. Same five sutures were applied when we performed intracapsular, but lens was not there. Now, after applying five sutures, some of the suture might be tight, some suture might be loose. At first post-operative day, the patient's vein is pretty good, maybe 618 or something, but uh, he might be having astigmatism because of, for example, this stitch is tight, so he will have astigmatism in a specific meridian. After 40 days are complete, we take off all the sutures off. After 40 days, the cornea attains its normal position, and the patient ideally should become 6 by 6. So this uh, large incision and the problem of astigmatism is the basic uh, problem which led ophthalmologists to think about, to invent uh, another procedure in which these issues are addressed during surgery. So phacoemulsification, which is now we have surgery which is even better than phacoemulsification. done by laser. This is called femtosecond cataract surgery. That is really a laser surgery. But patients and doctors even uh, misunderstood when this started, and still they misunderstand, and they still think that phacoemulsification is a laser surgery. Patient comes to you and asks मेरी सर्जरी लेज़र से करेंगे, तो हम कहते हैं जी, तो हमारा मतलब ये होता है कि we will do it by phaco, but actually phaco is not a laser, it is ultrasonic probe. Now we will discuss how we perform the phacoemulsification. I told you the previous previous surgeries, because now it will be easier for you to understand the phacoemulsification. So similarly, this is the limbus. This is the dilated pupil, and for example, here supratemporal part we give 2.8 to 3 millimeter in seal only, and this is the sagittal section, and we give a small seal. Uh, Now we first step is that we inject methyl cellulose, which is a viscoelastic substance. We inject viscoelastic in all the three surgeries, in the two previous surgeries which I told you, and also in this after viscoelastic, the function of viscoelastic is to maintain the um, shape of the eye, and after doing this, this is the anterior capsule. We perform CCC. CCC stand for continuous curvilinear capsule rhexis. In extracapsular cataract extraction, we performed cane opening, like जिस तरह हम cane open करते हैं, cane opening capsulotomy. But in this, it's a very needs a lot of practice. We remove the anterior capsule like continuously, and it is continuous curvilinear capsule axis. Now anterior capsule is removed, but in a special fashion. Here the things which I have left, these are the parts of the anterior capsule, because we have not removed uh, all the anterior capsule. This anterior capsule is still there. So we have the bag of the lens. Are you getting my point? If you have got any question in the mind, you may ask. So here is the nucleus, and now what we do? Phacoemulsification is a machine, small machine, portable, and it has a handpiece just like a pen, and a foot step. When you press the foot step, then the water starts coming out of this probe, and when you press it on the second step, there are three steps in the in your foot. On the first step, water comes. On the second step, it the probe moves in the ultrasonic speed, and it is cutting. So it's not laser. And in the third place, it aspirates. That is sucks. So first, then we enter into the anterior capsule. For example, I have given in scene here for better understanding. We have entered into the, this is the uh, this is the cornea, this is capsule. So I have given in CN here. Okay, here we have entered. After entering what will we do after capsulorhexis? We will go to the memory one or step one, and make a we will eat away the whole of the part of the nucleus. Are you getting my point? We are When we will press our foot, the probe will move in the cutting position, and we will put it over the nucleus, and it will eat away that part. It's very simple. And then we do it again. Then we rotate it. The nucleus, this part, we rotate it in the bag, and then for example, this after rotation, this groove has come to here. Okay. Now we again make another groove, and we make another groove a couple of times till we can see the fundal globe of the retina or choroid from behind. Now behind this nucleus is the again posterior capsule. Phacoemulsification is basically a refined form of extracapsular cataract extraction. Here also the key of the surgery is to preserve the posterior capsule. If posterior capsule is gone, then your surgery is gone. You are out of extracapsular cataract extraction. Then there are other modalities which you will have to perform. So, are you getting my points? So now we have made two grooves, and we have divided nucleus into four parts. Now we will make an opening here, and a small incision, a small instrument like handle or chopper, which is like a finger, and it's turned like this, and we pass it into the from here, and with the probe here we break these four parts separately into freely floating four parts. Now these are free floating four parts in the eye. Now we switch to the third uh, step, where the phaco power is decreased, because now we have cut the nucleus with ultrasonic probe, and now we just need to aspirate. So with less power, with phaco probe inside, we first of all remove one, second, third, fourth, ultimately all of the four parts of the nucleus, and now we are left with only cortex. This is cortex, between anterior capsule and nucleus is the third part, which is called nucleus. Nucleus is gone, and we are left with the cortex with two-way cannula. One at the one end is a syringe, and the other end is the suction cannula. You take out the phaco probe, and you enter it with the two-way cannula, and you remove it the cortex. Now you are left with just posterior capsule. Understood? Okay. Now we have incision of 2.8 millimeter, just 2.8 millimeter. Now the lens diameter previously was used to be 6.5 millimeter. Then it became 6 millimeter. Now for phacoemulsification from this incision it is not possible. Now we have 5.5 millimeter of lens, but even that is larger. So the lens comes in a foldable form. This is 5.5 millimeter lens which comes in injector. This is just like an injection in which the lens is present. We inject that lens into the eye, and when you it is foldable, then it is almost 2.5 or 2.6 millimeter, even smaller than the incision. We pass that injector into the eye, the lens goes inside, Okay, and then when you leave it, it automatically unfolds. And the haptic goes under the texas and the lens, and the second haptic goes here. And there is any so small that there is no need of any suture to be applied. Through a very small incision, 2.8 to 3 millimeter incision, we have uh, injected foldable intraocular lens into the eye. Now the surgery is over. At the first post-operative day, there will be no astigmatism because there are no sutures. And if the surgery is gone smooth, there is no problem. Patient ideally should see 6 by 6 at the first post-operative day. This is the basic theory of phacoemulsification. Now, if you would see the video from YouTube, I feel that it will be more understandable for you. Thank you.